I want to give a warm thank you to the research data centers. I started my career in 1995, just as the National Population Health Survey started to be gathered. And following that, there was the Canadian Community Health Surveys and the longitudinal study of immigrants to Canada. So I based my career and many a long and happy hour at the Toronto Research Data Center. So it's a real pleasure to be here with you today. I'm going to be talking about a group of studies that I've done using RDC data, looking at the early adversities and long-term health and physical health outcomes, focusing today on childhood physical abuse. So the overview is that I'll talk about sort of previous studies on childhood adversities and health, and talk about potential pathways linking early adversities to health. And description in this case is mostly of the Canadian data set I've focused on, and findings for 10 health outcomes and other child adversities linked to poor health, and then potential explanations, which again are outside the realm of observational data that I have access to, but just trying to think outside the box about why these associations may exist. So I was a social worker back in the 80s, and I wish that I had had this eureka moment, because I was working with people with a wide range of different health issues, but most of them ended up coming from very difficult backgrounds. In the 1980s, people were beginning to talk about incest for the first time in history, basically. It was so people were coming to me as a therapist asking to talk about those issues, but they were dealing with many, many health outcomes, whether that's being obesity or COPD or a heart disease. So I didn't see a pattern, but this fellow, Vince Folletti, was really the first person to sort of see a pattern. He is a doctor in the US who specializes in obesity, people who are morbidly obese, and was having very outcomes non-surgically, and yet he'd find after a while that people were actually, they'd lose a lot of weight and then they'd start putting it back on. And he started interviewing them, and he found that many of them were childhood sexual abuse survivors. And when they became thin, they felt vulnerable. If somebody hit on them or anything like that, they were more likely to gain weight back again quickly. But he just found patient after patient after patient had this history. So he did a very big survey looking at early adversities, a whole range of psychological adversities, physical abuse, sexual abuse, parental divorce, parental domestic violence, substance abuse problems in their parents, parental mental illness, or parental suicide, or prison. And there's 0 to 7, and he found what we call a dose response. So each additional early adversity that people had, they had a higher likelihood of almost every disorder. To the point that he looked at heart disease, cancer, stroke, diabetes, hepatitis, skeletal fractures, all of those were highly associated in a dose response fashion with the early adversities. And most devastatingly, people with 6 or more ACEs, so we call adverse childhood experiences ACEs, those individuals had a really chaotic childhood, and they died on average 20 years earlier than those who had no ACEs. So he looked at a health maintenance organization. There was another study on national comorbidity, also finding a high association between childhood physical abuse and a wide range of outcomes. And another study found was the Wisconsin longitudinal study that had been following people since they graduated from high school in the 1950s. And again, found that childhood physical abuse was associated with allergy and arthritis, asthma, circulation problems, high blood pressure, heart troubles, peptic ulcers. And they were controlling for age, sex, family background, and other childhood adversities. So what was going on with childhood physical abuse? The question is, what could explain the link? So we had some hypotheses. If we were in person, I'd really love to have a little dialogue with you about this. But Here's some potential pathways. Could it be that it's not childhood physical abuse, but it's other childhood stressors? So people who are physically abused were also more likely to be sexually abused, to have parental domestic violence. So it might have been all of those things together rather than just the physical abuse. There's a lot of literature on health behaviors, lower socioeconomic factors going forward, marital status, and mental health. So it could have been any of those avenues. So childhood maltreatment really is often concurrent with parental addictions, parental conflict, household poverty, and it's these convergence that may be part of the problem. Here's a paper that we did using 1995 and 2005 data. From 1995 was the National Population Health Survey, the 2005 was the Canadian Community Health Survey. So we found if you had no risk factors, in other words, you didn't have parental addictions, parental divorce, the prevalence of childhood physical abuse in both studies, you can see, was about 3.4%. But as you added one risk factor, two risk factors, three risk factors, you're getting up to more than a third who were physically abused. We found similar data about sexual abuse, that there was this huge tenfold increase in risk by the time you had three risk factors. This one is looking in US data, looking at physical abuse and sexual abuse. You can see the same type of ratio. And this is actually forced intercourse, the most extreme form of sexual abuse. And you have more than a quarter of women who have experienced three risk factors have been sexually abused before the age of 16. So health behaviors is another potential avenue. So it could be that people self-medicate, cope with adversities through unhealthy behaviors, whether that's smoking or obesity, overeating, which leads to obesity, or alcohol use. So there's a lot of research on that. We looked at obesity, and we found that women who were physically abused had 35% higher odds of adult obesity when adjusting for 13 other known risk factors. So it was quite a robust relationship. Men, there wasn't an association. We looked at smoking, and we found that all 6 types of adverse childhood experiences, each one independently was associated with ever smoking in women. But among men, it was sexual abuse and verbal abuse that was associated with ever smoking. Quitting smoking is a bit different than ever smoking. So once you're addicted, it's harder to break out of that. So for men, we found household drug use was significant. For females, physical abuse was still significant. I haven't done this research yet, but if we live in a country where we can't even walk our own dog, then clearly we need to look at the association between early adversities and physical inactivity and see if that's the root. Socioeconomic factors. There's a lot of research saying that those experiencing childhood abuse often go on to have greater disadvantage in adulthood. So not just that they were poorer in childhood, which is often the case, but even among those who are middle class or upper class, the childhood physical abuse tends to result in them having a downward mobility in adulthood. And there's a lot of literature on greater educational difficulties and poorer outcomes and a decline over time. So one of those avenues may be through, or two of these avenues through ADHD and dyslexia. In the general population, only about 7% of those without ADHD or without dyslexia reported childhood physical abuse. But if they had ADHD, about 30% reported they'd been physically abused in childhood. And among those with dyslexia, it's about 35%. I don't know for sure if it was a parent who was causing the abuse, but those numbers are disturbing. It warrants the idea, should we have targeted screening for abuse among children with ADHD and dyslexia, since such a large number are exposed? So there's a lot of research. This picture here is actually Whitehall, because there's a famous Michael Marmot study that followed civil servants and showed that with every level that you go up in the civil service, your risk for poor health outcomes comes down. Early people who've been physically also have greater exposure to divorce. They're more likely to get divorced, less likely to marry, and marriage is very protective for health, particularly for men. Now, mental health, there's a lot of literature on that, so I'm not going to go too much into depth on that, because early adversities totally make sense and has been known for decades that it predisposes people to depression and anxiety. And mental health is a risk factor for a wide variety of physical health outcomes in the general population, including things you might not think of, like heart disease. We use the longitudinal National Population Health Survey to look at the association between remission from depression. So we know that early adversity puts you at risk for greater depression, but we said, okay, now among those who were depressed at baseline, which was 1995, if we follow them forward, how long does it take for them to come out of depression? And we had about 1,100 people who were depressed at baseline. We found that those who reported that they'd been physically abused during their childhood took 9 months longer to remit from depression than those without an abuse history. We followed them for 12 years. So in other words, it's not just that you're more likely to succumb to depression, it's harder to shake it if you have a history of childhood physical abuse. We also looked at suicide attempts. Childhood physical abuse was associated with 4 times the odds of suicidal ideation among women and 3 times the odds for men. Sexual abuse, it was 5 times for women and 2.5 times for men. But we also looked at other types of abuse, that like chronic parental domestic violence. And then by chronic, we decided it was 11 or more times that their parents had abused each other. And that was associated with double the odds of suicidal ideation for women and triple for men. And the 3 forms of maltreatment together explain 19% of the variability in suicide and 8.4% for men. So those of you who do quantitative large surveys, research, 19% is a pretty high explanatory value, because I don't have things like depression in there. I have a history of maltreatment. So the Canadian Community Health Survey in 2005 also had these questions on childhood physical abuse. So I started working in the 1995 survey, but the 2005 survey was great. We had 84% versus 83% response rate, and had about 5,000 males and 7,000 females. So the preamble to the question was, were you ever physically abused by someone close to you? And 7% of the full sample reported that they'd been physically abused. The health conditions were based on self-report of a medical diagnosis. So here's one example, cancer. So if we just adjusted for age, race, and gender, those who were physically abused had about 49% higher odds of reporting that they had they'd been diagnosed with cancer. I put in other childhood stressors like the parental divorce, et cetera, and parental addictions. Those ones didn't really move it. The difference between 1.49 and 1.52 is that's just modest odds. Again, adjusting for health behaviors like smoking, drinking, inactivity. And it's not that those aren't really important for cancer. It's just that they don't explain away the direct association between physical abuse and cancer. We put in adult stressors, which were sort of stress, social support kind of issues. And again, it doesn't move. So when we've adjusted for all of the above, which is a huge number of variables, it went from 1.49 to 1.45. In other words, childhood physical abuse is uniquely or independently associated with cancer, and it's not explained by the usual suspects. This is a bit of a spoiler alert, but we looked at 10 different outcomes, and almost every one after full adjustment is somewhere between about 35% and 85% higher risk. So childhood physical abuse increases the risk even when we take into account all of these things. So This is the heart disease. So they have about 57% higher risk when it's just age, sex, race adjusted, 45% after full adjustments. Osteoarthritis, 56% after full adjustments. So those who were physically abused had 56% higher risk or higher odds of osteoarthritis. Migraine was 77% higher odds. It declined a bit when I controlled for a variety of different things, but it still was at 36% higher risk or higher odds. Peptic ulcers were at about 68% higher odds. Now we know that H. pylori causes it, but somehow the stress interacts with it. Thyroid's 40% higher odds. Chronic fatigue syndrome had twice the odds. Fibromyalgia, 65%. Multiple chemical sensitivities, 2.8 times. So the idea is that maybe that we have biological embedding, that actually the early adversity changes the way you react to stress throughout your life. And maybe that's what's causing the problem. It might be changing your HPA axis, and changing the way your cortisol or fight or flight hormone works, and or chronic inflammation. Thank you so much. I'd be happy to talk more with you during the discussion.
So the title of my presentation today is Urban Income-Related Health Inequalities in Canada, Key Findings and Their Implications. My name is Charles Plant, and I'm a research scientist at the Saskatchewan Health Authority and an adjunct professor at the University of Saskatchewan. But previously to this, I was a research officer with the Urban Public Health Network. Between 2017 and 2020, I worked with the UPHN and our partners at Statistics Canada and the Canadian Institute for Health Information to try and update the record on health inequalities at the city level in Canada. My primary co-authors on this work were Dr. Corey Neudorf and Sherilyn Missiuna, and my presentation today is going to focus on presenting some of our results. For context, the Urban Public Health Network consists of the top public health doctors for each of the largest cities in each province, or for some of the largest cities in each province across the country. Collectively, the UPHN is actually responsible for the population health of more than 60% of Canadians. The report that we've put together based on this work is called Urban Income-Related Health Inequalities in Canada. It's available on the UPHN website under inequalities, and it was released this past spring. It was a little bit delayed due to COVID-19. Has some important predecessors, starting off with Canadian Institute for Health Information's Reducing Gaps in Health, a focus on socioeconomic status in urban Canada, but also, which also did city level analysis like the work that we did this time around. It came out about 10 years ago. We've also seen some useful reports in the last few years from Public Health Agency of Canada, as well as Canadian Institute for Health Information, looking at health inequalities at the provincial level and at the national level, and for some of the largest cities in a couple of instances. In this talk, I'm going to move through 4 key points. What are health inequalities and why do they matter? And then I'm going to talk about how we calculate health inequalities for these reports. I'm then going to move on to talking about some of our key findings, just provide a bird's eye view, because there's a lot of numbers, as you can imagine, that's been involved in this work. And then I'm going to talk to some of the implications of what we see as some of the implications of our findings for research primarily, because that's what we're here to talk about today. So first, what are health inequalities and why do they matter? Health inequalities, simply put, are just differences in health between groups. When we're talking about population health, we're talking about health of groups of individuals. So that health is going to have a distribution. It's going to have a central tendency and dispersion. But the reason that we're really interested in health inequalities is because of the relationship to health equity. Health equity refers to differences in opportunities for accessing health, usually unfair, but also sometimes defined as differences in health that we can change. The reason why those are so important is partly for social justice reasons, but also from a policy perspective. It turns out that a lot of actually the majority of the differences in health that people experience tend to have less to do with what we think of as more traditional drivers like biology or genes. It's really people's social circumstances, and that's where equity comes into it. The UPHN, it's been important to look at the city level because the members operate at the city level, but also because just generally in Canada, health implementation really happens at the local and regional level. Standards might be set at higher levels, but when it comes to where the rubber hits the road, so to speak, it really happens at the local level. We've also found, and I've also found through my work, that the city level is also the level at which the public generally experiences their community and their health. People relate to city level numbers in a way that higher level numbers seem more abstract to them. It's not the number per se that's abstract. It's not numbers per se that's abstract, but the unit of analysis that feels abstract to people. Another reason to go to the city level is that there's just a lot more cities in Canada than there are provinces, and so there's a lot more opportunity to gain insights through comparative work. Nonetheless, as I'm sure most of you are well familiar, there's also some large challenges in going down to the city level. Oftentimes there's just the population may not be there, or the sample size might not be there. In our experience, data infrastructure is also lacking at the city level for a variety of capacity reasons. They're associated with limitations on municipal governments and so forth. Sometimes when the data can be accessed, there's concerns around disclosure that prevent us from being able to do research at that level. When we get through all of these hurdles and research finally is done at the local level, it's so much work sometimes to get that done for one city. Nobody ever gets around to doing it for another city. And so a lot of research in our reviews and things that we've done, literature reviews, we found that a lot of city level research tends to only look at a couple of cities. So we wanted to take the broadest possible look. So how do we calculate health inequalities in our research? Well, we focused on income-related health inequalities, and I'll talk about what we mean by income in a second. But first, the main thing that we did, and I should also mention too, there's different measures of inequality that we considered, but we decided to stick to a couple that are a little bit easier to work with because our goal was really more on the side of knowledge mobilization. We want to generate numbers that decision makers could use. And so we zeroed in on the rate ratio and the rate difference. And basically what those involve is calculating health status for low-income communities and high-income communities within each community, within each city or municipality that we looked at, and then just comparing those differences, either in terms of their relative differences with the rate ratio or their absolute differences with the rate difference. In order to operationalize income, we assign people based on their neighborhood. So it's an area-based measure of income, and that was done using the PCCF Plus. There's a variable that comes along with it called CAPE, which some of you may be familiar with. This is the income variable that we use, but it's average DA income. And you can see on the right, we have a picture of Saskatoon, where I live. When I talk about the city or local level, we operationalize that in each of two ways. We use the CMA, the Census Metropolitan Area, and we did an analysis. And then we also actually went down to the census subdivision or municipality level because it was really important, especially in some of the largest CMAs in Canada, to be able to break out different communities within these large areas. So, for example, to break out Surrey from Vancouver or Mississauga from Toronto. We looked at 29 different health outcomes across both hospitalization hospital utilization indicators and self-reported indicators. Our collaborators over at the Canadian Institute for Health Information handled the hospital utilization indicators, while our team, our UPHN research team, focused on the self-reported indicators, which are found in the Canadian Community Health Survey and were accessed through the RDC here at the University of Saskatchewan. In order to drill down to that level and address some of the problems that I mentioned earlier, or challenges that I mentioned earlier, we had to come up with some innovation. We had to innovate a little bit. One was taking as our unit of analysis 5-year between census intervals, basically pooling data to be able to get higher counts, to be able to drill down to a higher resolution geographically. We also adopted an indicator by indicator approach, which meant that we didn't look for indicators that were necessarily workable for every size city. And we didn't only look at indicators if it could be done for, or we didn't only generate results if it could be done for every city. What we basically said was we're going to use every indicator that we can for every city that we can, and we're gonna release those results. And we're just going to recognize that some places are just too small, and so they're going to have missing observations or missing values. This allowed us to do quite a bit more analysis than previous efforts. And then finally, we had to work very closely, both on the CIHI side and on the RDC side, working with our analysts and to develop vetting standards to deal with these sort of new pooled between census year intervals and think through some of the risks and trade-offs around doing city level analysis and data sets that weren't necessarily designed to be pooled or to go down to that level. We have distilled the bulk of the work. As I said, there's a lot of numbers, but there's sort of 4 key findings that we think really jump out to us and are worth sharing, and we hope can provide a bit of a foundation for more in-depth investigation by ourselves and others. The first is that across the board, income-related health inequalities are widespread in Canada's cities. Across all indicators in every city, we found a health gradient, and the gradient was the direction that you'd expect, with better health outcomes for higher income communities and lower health outcomes for lower income communities. This having been said, there was also lots of variation in these health inequalities between communities and between cities. And it was very uneven. We didn't find that one city tended to have all the health inequalities, and we didn't even find that one city had all the same types of health inequalities. It really was all over the map. If anything, we found the health inequalities are widespread, but we didn't necessarily find that any city outperformed others. What we found was that different cities tended to exhibit different patterns of health inequalities. And in the report, we comment a little bit on what could be driving that, some of those trends. The third finding that I think personally is quite interesting is when we dug a little bit deeper into these differences that I was talking about earlier, that I was describing earlier, between low income and high income, and we looked at them separately, we found that a lot of the variation between cities was actually really taking place in the low income communities. It turns out that in Canada's urban communities, the wealthier populations or the wealthier neighborhoods are roughly have about the same level of health. It's really when we're seeing this variation from place to place and differences and inequalities, it's what's happening in the lower income communities is driving that. Finally, we also looked at things over time, and we found that on the whole, despite a lot of talk about health inequities and the need to address them, we haven't really seen improvements over the last few years. In some instances, we are seeing improved outcomes among some groups, but it tends to be concentrated in the higher income groups. And as you can see with a couple of examples that I provided here, that can actually lead to increased inequalities if we, if policy measures aren't reaching everybody yeah. So finally, in terms of some sort of high-level implications and concluding remarks, I think this research is motivating. I hope it's motivating Toulouse to think a little bit differently about health governance. It's really easy to, when all of our data is at the provincial or national level, to think that health is determined by decision makers at those levels. But what we're seeing in our work is actually in some indicators, we're seeing as much variation between cities and health inequalities as we're seeing between provinces. Like, we're seeing more variation within provinces than between provinces. And this suggests that, the province is definitely not the whole story. I think on the one hand, it could be pointing to potentially missed opportunities or a lack of provincial levels adequately doing enough to ensure that their health services meet the needs of local communities. That would sort of be a more pessimistic take. But it could also be that some local communities are just doing a really good job, and that local level decision making and practice is having an impact. I actually think it's, as is often the case with these types of either ors, it's probably a little bit of both. Looking ahead, my team, and I hope others will be, my team is very interested in, and I hope others will be interested in going to the next step and unpacking and maybe starting to answer, what are the key drivers behind this in the years to come. And we're already working on some of this. We're planning to extend this analysis to other indicators of health status, such as in vital statistics. We really want to start working on articulating the causal determinants and identify local level policy levers, and so really, bringing that whole model out. And because we're doing this comparative work, we actually have the variables that we need. We have the variation that we need to start to articulate that type of model. And then as we go forward as well, to begin to, I mentioned that we already started to do a little bit of this in the report, but really begin to theorize, why do we have such large differences in health status, especially inequalities in health status between places? And then finally, I mentioned that this report was updating the record after a decade. We hope in the years to come that this kind of work can also, more city level reporting can sort of happen routinely, as opposed to just intermittently and ad hoc, resources permitting going forward. So that's my presentation for today, and it's very high level, but I hope that maybe there were some interesting findings in there, and I look forward to answering any questions that you guys might have and discussing further in the Q&A period that's going to come up. Thank you, and thank you.
Thank you to our three presenters for such great presentation. I feel privileged to see how StatCan data can be used in research. As part of my work, I see all RDC access proposals coming in StatCan, but I rarely have the opportunity to see final research paper being published. Most importantly, I can appreciate on all findings presented today can improve health services and provide a better understanding of population health. I could relate myself to many situations I've been exposed to in my previous career as a kinesiologist. I also noted data challenges raised by Dr. Plante, as we are constantly working on addressing data gap in StatCan and offer more data through the CRDCN. So some questions already been answered in writing. So now let's open the floor to live question, and to any participant who would prefer to ask their question in French, please feel free to do so. I will do my best to do the live interpretation myself. So the first question is for Dr. Plante. Were there differences in the age profile or other demographic characteristic between the cities that might explain why there was why there was so much heterogeneity that you saw?
Yeah, so So I didn't mention it, but so the results that I presented there and that show up in the report are age standardized. So in theory, we're supposed to sort of be controlling for the age profile question. But that being said, we do think that at least some of the differences that we're seeing between schools are driven by differences in social demographies of the populations. And we see that as sort of one of our next steps is to sort of start doing those types of decompositions and separating stuff that's just because of different types of people and stuff that's more because of different types of policy response. That said, I think we're also mindful though that even if it is, the reason we wanted to do it without too many controls at the start was that even if it is because of different, if it's because different types of, even if it's compositional things that are driving things, like the commitment to health equity is a commitment to provide health access to everyone. And so it doesn't necessarily, just because it's a compositional difference doesn't necessarily justify those differences, right? And so we think it's important to start with that sort of unconditional number before we start unpacking it. And hopefully, as you understand which populations, that also gives us some insight into how we can actually tailor things to meet those differential needs.
Thank you. Any other question for our presenter today?
I have a question for Chuck because that was really interesting. I'm just wondering how you go about, because it's occurred to me as well, how it's harder maybe to get a really good idea of the policy landscape at the municipal level. Like, how would you kind of figure out what those policies are to make that link with what you're finding?
It is really hard. Yeah. So that's actually been, so our UPHN research unit, we sort of have two different prongs. We have a couple prongs of research. And so one of them is this inequalities work, is trying to describe the outcomes or the health outcomes at that level. But we also have one where we're trying to actually gather information at the municipal level on the policy side. And so one way that we've been doing that is like using our existing networks through public health and talking to public health doctors and also public health, like just staff generally, who tend to have a sort of on the ground understanding of these things. And we're still trying to work out the best way to gather information from those sorts of local level experts. And then also building partnerships with other groups that have an interest in local level analysis, whether it's like transportation stuff or whether it's municipal policy. But there is a lot of work to do in the years to come to get those surveillance systems in place for local level policy analysis.
It's not as easy as just going to a librarian and doing a systematic review, eh? Yeah.
No.
Yeah.
I actually had a question for Chuck too. I enjoyed both the presentations, but Chuck, I was wondering how straightforward would it be to apply these same strategies to COVID-19? That's immediately what popped to my mind is like, oh my goodness, how is there variation in the impact?
I think the biggest hurdle we're going to run into with COVID-19 is that so much of COVID-19 data is public health data, and public health data just doesn't show up in any of our RDC data, like national level data. I do have some projects kind of working on that, but it's like public health microdata is like not really a thing. That being said, we also have some projects looking at COVID-related deaths, and that will show up in the vital stats data that we do have access to at the national level. But then you run into sample size problems too. It's just, I think we could stratify that and look at inequalities, but I do see us kind of going in this direction and doing some of this work in the next couple of years, but it's going to be tricky because of these data access issues.
What about hospitalization rate, sort of, which is a measure of severity, I guess?
That's a good point. I haven't looked at I'm less of an expert in the hospitalization data to know to what extent the data is capturing hospitalizations due to COVID. It must be. Maybe someone else, maybe somebody who's listening can speak to that.
I'm literally writing a grant about that as we speak.
Thank you. Our next question is for Esme. What kind of policy implication come out of all those findings? There's such a bleak picture. What do you think should be done?
Oh, yeah, I'm a bit of a Debbie Downer. I realize when I present, it's all the negative things. In fact, I have published on sexual abuse survivors who are thriving. So they're not, as adults, they're not just not depressed or not suicidal, they're actually happy and flourishing and have warm and supportive relationships. So I don't want to, this is a heightened risk, but it is not universal by any means. So let me do that as step one. Step two, I think it's certainly, there's a whole realm, but let's start with primary prevention. What can we put in place to stop abuse and support very poor families? I mean, abuse happens across the whole continuum, but the more stressed the family is, the more likely that the abuse occurs. So making sure that the minimum income of our poorest individuals is sufficient to put food on the table and to decrease stress in the home environment. I think more awareness of teachers, of communities, of support people, having public health interventions, for example, right at childhood, at babyhood, you know, where they have public health people coming in and helping. So primary prevention would make a huge difference the whole way down the trajectory. Once people have been abused, even in the child welfare system, unless they're self-mutilating or seeming to be very dysfunctional, children don't automatically get cognitive behavioral therapy. There is a huge body of evidence that cognitive behavioral therapy for early traumas makes a big difference and changes the trajectory. It is not a big ask. We're talking 12 to 16 weeks, 1 hour a week therapy. Every child in our country who has been abused and at least has come to the attention of the authorities should be getting that intervention immediately. They shouldn't have to be self-harming before we finally make them to the top of the list. So I think there's a huge amount of interventions we can make at the child level, but even at the adult level, some of those behaviors, you could see the odds ratios were attenuated when we controlled for health behaviors. So interventions to help with trauma can also help with smoking, drinking, obesity, but stress, coping, CBT for adults. Let's not have 5-year waiting lists to get into a mental health system as adults or as young adolescents. What are we thinking?
Well, thank you. Keep your mic open because the next question is also for you, and it's from a former colleague of mine, I believe, Hélène Bergeron. Bonjour, Hélène. So the question is, do we know what age groups are more vulnerable to develop diseases in adulthood?
So I'm just wondering, is that the question about at what age the abuse occurs, having that long-term consequence? Because of course, typically it's older adults who would develop the disease. But the name of the institute at University of Toronto that I run is called the Institute for Life Course and Aging. So in fact, I'm a gerontologist. I used to do all my research up here, and then I realized, I'm not dealing with the causes, and I kept on going backwards and backwards, and I'd go prenatally if I had the data, definitely. We have a whole continuum. So I can't answer the question in that exactly what is the highest risk group, because I just know that these occur before the age of 16. And it may be different types of abuse have different consequences. I focus by discussion on childhood physical abuse, but I've done a lot of work on sexual abuse as well, and also on lesser studied early adversities. For example, parental incarceration doubles the risk of heart disease and diabetes, and parental divorce increases the risk in men of stroke. So there's lots of different adversities, and they may have different trajectories, and I'm not sure exactly what period people are most at risk.
Thank you. The next one is a comment from Alan Diner. All very interesting presentation. And he's saying, speaking of hospitalization info related to COVID, my team at Health Canada are doing some work in that area using the discharge abstract database, open year data, which has a lag of about 3 months. Happy to connect on that. Wow. Thank you, Alan.
And fantastic.
And the next one is for you again, Dr. Fuller-Thompson. For immigrants who were abused during childhood in their home country, how can they be helped?
Well, I'm assuming that means that they're adults now. And so the cognitive behavioral therapy that I mentioned for children, there's trauma-focused cognitive behavioral therapy for adults that also has very good impact, decreases post-traumatic stress disorder levels, depression, anxiety. And I mean, I'm not going to live long enough to see studies that follow people forward, but our belief is if we get these mental health risks down, we'll probably also see a decrease in the physical health outcomes as well. So it's never too late to get help, and there are some good interventions out there.
Thank you. The next one is for Charles. Curious why QAI PPE was used rather than other neighborhood disadvantage measures such as Pamplon Index.
I have so much to say about this. We actually have a whole working group starting to look at this problem right now, or this question right now. But the long story short is, what we haven't found in some of our work that's sort of unpublished over the years by some of my colleagues, that you don't actually get really different results when you use the Pamplon Index or other material deprivation measures, but you end up with a more complicated stratifier that makes it more difficult to communicate findings to a general audience. And so there just isn't enough payoff in moving to the Pamplon Index. But that's saying, like, we do use the Pamplon Index in some of our work, and not like anti-Pamplon Index or anything. That was just something that was decided. And that was actually one of the major differences between our update to this work compared to what CAIHE did 10 years ago, because they did use the Pamplon Index at that time. I also have problems with CAPE itself. Like, I don't think it's calculated very well, and I have my own way of calculating it when I work with census data directly. Why not use median VA income? But anyways, that's a whole other digression. Thanks for your question, though.
Thank you. So I believe this was our last question. So Dr. Fuller-Thompson, Dr. Dasgupta, Dr. Plant, thank you again for your participation today. And for all participants, I would like to remind you that our next session is in partnership with the University of Toronto School of City, leveraging microdata for urban research across discipline. And this will take place on Monday, October 25th at 1. So there is still time to register for that session if you haven't done so. So thank you again, everyone.
And thank you, Geneviève. We couldn't do it without the RDC data. So we're so pleased that you guys are working hard behind the scenes. So your whole team, congratulations.
Thank you. For sure, I always bring that back to them, because seeing how the data is useful is always a great driver for motivation on the work that we're doing. Thank you very much.
Thank you.
Thank you.